Are we on air?
We are, yes.
Okay, brilliant. Well, apologies to everyone for running a few minutes late. We've had a few technical issues. Good afternoon and a very warm welcome to this exciting webinar focusing on CVD Prevent, the new national primary care audit aiming to identify health inequalities in relation to the prevention of cardiovascular disease. I'm Yasser Javed, and please ignore what's written on the screen on my picture. That's the incorrect job title. I'm a GP with a specialist interest in cardiology and cardiovascular lead for my CCG in Northamptonshire. And it's a privilege to be chairing this meeting, and we have a wonderful array of expert guests. The meeting has been kindly funded by a non-promotional educational grant from Daiichi Sankyo. Just move on to the next slide. Are we on to the next slide? Okay, please do ensure that no non-registered attendees can view or listen to this webinar, which will consist of both live and pre-recorded sessions, as well as 3 polling questions requiring your sort of interaction. These meetings are always so much more impactful with audience participation. So I'd encourage liberal use of the chat panel function to pose questions and comments that we'll endeavour to address during the Q&A session at the end. We'd also be grateful for your completion of an evaluation at the end. Right, I think there should be the housekeeping slides coming up, but it looks like it's a different set of slides. But if I think I've run through my disclosures. So over the next hour, I'm sorry, guys, I have no idea what slides are being presented, but it looks like it's not the housekeeping slides. Is it, Ravi, what slide are you seeing?
I'm just seeing you, actually.
There's no slides?
No.
Can we please play some slides? Aha. Okay, brilliant. Thank you very much. So those are my disclosures. And look, over the next hour, we'll be giving you an overview of the initial findings of the CVD Prevent audit, identifying the unmet need and opportunities that the findings represent. We'd also like to share a wonderful case study of a joint working project between Leicestershire Primary Care Cardiovascular Hubs and Daiichi Sankyo UK, which will hopefully offer some food for thought. And we're in for a treat because we've got a fantastic faculty to offer their great expertise. Dr. Peter Green is the clinical lead for CVD Prevent. Vishal Mashru is the head of medicines and research at Cross Counties Healthcare and North Blaby PCNs in Leicestershire, which is in the East Midlands. And last but by no means least, we have, I'm told, the very dynamic, charismatic and impressive medical director of Daiichi Sankyo UK, Dr. Ravi Pawar. And I firmly believe that the NHS must find more innovative ways of working with industry for mutually beneficial outcomes for the benefit of our patients. So here is our agenda. I'll be kicking off by setting the scene for cardiovascular disease Prevent, CVD Prevent, and its clinical rationale. Peter will report the key finds of the first audit report. Vishal will share the perspective from his local PCNs, and Ravi will round things up by highlighting how Daiichi Sankyo can and actually is supporting the vision of CVD Prevent. And we'll hopefully have some time for Q&A, and I'll do my best to ensure we finish on time. So why is CVD Prevent such an important initiative? So if you can just put my slides up now, whoever's in charge of the slides. Can we put my slides up? These slides have come to an end on my dashboard. Brilliant. Oh, it seems to be the same slides. Here we go. Brilliant. So quite simply, cardiovascular disease is the, well, I would consider it the original modern global pandemic of the 21st century, the single biggest global killer and responsible for over 25% of all deaths in the UK. But more importantly, It's one of the leading causes of premature and preventable mortality, morbidity, and sadly disability. So it really is a tragic fact that many of our patients lose many good quality of life years to cardiovascular disease. And here is a prime example. You can see a CT scan showing a patient suffering a devastating cardiovascular event, a massive stroke. And we can all imagine the devastating impact of these catastrophic events, resulting not just in huge healthcare costs, but tremendous social costs. And most importantly for us, certainly for us as clinicians, the tragic but potentially often avoidable human cost. And the most common underlying disease process for most cardiovascular disease is atherosclerosis, a process which for most of us starts in our teenage years. And the quicker and more diffuse and advanced the progression, the greater the risk of an atherosclerotic plaque rupturing, releasing a whole cocktail of clotting factors, which results in rapid thrombus formation and occlusion of the artery, causing devastating ischemic damage to either the brain, heart, or peripheral vasculature. And these horrific cardiovascular events, this is a disease of both women as well as men. In fact, we know far more women die prematurely from cardiovascular disease than cancer. And I don't like this slide because this illustrates this huge postcode lottery variation in premature mortality rates from cardiovascular disease, despite NHS England reinforcing that dying below the age of 75 is a preventable and avoidable event. So it can't be right that in the UK, a modern progressive country, that a patient in the most deprived area of Manchester has over a fourfold increased risk of dying prematurely from cardiovascular disease compared to a patient little over 200 miles away in a leafy suburb of Hampshire. You know, that's not right. It doesn't sit comfortably with, I'm sure, any of us. And I'm very passionate about this. I think there are some areas of medicine that are so critically important, like cardiovascular disease prevention, where the evidence and guidance are so clear, overwhelmingly robust, the consequences of getting it wrong so catastrophic. We must ensure a systematic approach so all patients, irrespective of age, sex, ethnicity, and deprivation, all of these patients should have access to the very best available evidence-based and guideline recommended treatments. This is an area of medicine that deserves, more so than any other area, a standardized delivery of evidence-based care. So atherosclerosis starts very early on in life with endothelial dysfunction. You know, by our teens, unfortunately, most of us have developed fatty streaks. How these progress or how quickly these progress to plaques, significant plaques, depends on a variety of risk factors. You know, many of which we can't influence. The non-modifiable risk factors of age, being male, certain ethnicities, like South Asian, for instance. And I guess you just got to be lucky. But more importantly, we should be focusing on those risk factors that we can influence, in particular lifestyle, healthy living. You know, that has to be the foundation of any cardiovascular prevention strategy, but also not forgetting the blood pressure, lipids, CKD, AF and diabetes, each a significant independent cardiovascular risk factor in their own right, and risk factors that we should be proactively addressing for our patients. And there is a huge priority now given to cardiovascular disease and cardiovascular disease prevention in our current NHS long-term plan, which acknowledges, you know, this is really an area of medicine with the greatest opportunity to save lives over the next decade. But we must do this systematically to address the unwarranted variation in health inequality. And we're all familiar of the ABC for atrial fibrillation, blood pressure, and cholesterol. You know, if we can systematically improve detection and management of these risk factors, we can make potentially a huge dent in this huge burden of catastrophic cardiovascular mortality, morbidity, and disability. And cardiovascular disease prevention is, in my opinion, CVD prevent, you know, this audit is, in my opinion, a wonderfully exciting innovation to facilitate implementation of this long-term plan, involving the systematic audit of primary care of 6 key clinical areas highly relevant to cardiovascular prevention. And we mustn't think this is about trying to name and shame poorly performing areas. What it really should be about is peer comparison to motivate behavior change by highlighting those areas of unmet need and opportunities for improvement across PCNs. So I think if we can come to our first poll before Peter offers his presentation. We've got a poll to sort of gauge your perception of some of the important issues. So if you can put the first poll up, guys. Do you know what? I'm going to use my executive powers as chair. Let's move on to the first session. It now gives me great pleasure to introduce our first session, focusing on the key findings from the first audit, annual audit report, which I'm personally very keen indeed to hear. And who better than Dr. Peter Green, the clinical lead for CVD Prevent, to present it. So over to you, Peter.
Peter, can you turn your audio on, please?
Sorry about that. Okay, so hopefully you can all see the slides here. So thank you very much, Yasser, for the introduction. And clearly CVD Prevent is really important. What we're trying to do within this audit, and this is the first audit that covers the period up to the end of March 2020. The second audit covering the period to 2021 will come out in a couple of months, and then the third audit will come out in the autumn of this year, covering the period up to 2022. And the idea is that these will then roll quarterly, so you'll get some information about how things are progressing. And very much in terms of audits, so I'm a practicing GP, I really hate audits that come out that tell me that 18 months ago I missed something, that I could have done something better than I've done it at the moment, and reports that tell me that 10 of my 17,000 patients I could have done a better job on. And it's really frustrating, that sort of report. So when we've done the CVD Prevent report, we've done it in parallel. So this report looks at what the information is from primary care systems, but we're also working in parallel with other providers. So Matt Kearney, who was one of the initiators of this report when he was National CVD lead for the NHS. So the tools they have to be able to run searches in your own GPIT system to find the individuals. So hopefully this type of report will give you information on where to look. That sort of report will give you information on who to actually look at and who to make the difference to. So I'll work through these slides. So these again are just my disclosures. First report, the key findings. So again, and as we've heard, this has been a long time in gestation. There have been many reports leading up on the importance of cardiovascular disease, the importance of being able to prevent cardiovascular disease. You know, we know how to measure blood pressure. We know how to treat blood pressure. We know the same for cholesterol, for AF. A lot of the failure here is a failure of application of knowledge, not a lack of knowledge. That's not a criticism of anybody, because we're all working really, really hard. We've all got really busy jobs, and patients don't come in and present with high blood pressure and high cholesterol. These are essentially asymptomatic conditions until they get to a very severe stage. So we have to look for them. We have to screen for them. We have to think about it. These just give me a couple of slides here on the breakdown of who's responsible for what part of it. I won't dwell on that other than to say it's very complicated. I work for the bit that's part of NHS benchmarking, who produced the report, having got the data from Public Health England or the OHID. There is no patient identifiable data that comes across to us, and there's no patient identifiable data within the audit. And again, this is how we sort of set out the drivers, you know. So the national strategy is to reduce these 150,000 strokes and heart attacks within the next 10 years. And so we looked at sort of 4 key questions. You know, are we finding these people? Once we've found them, are we diagnosing them? Because unless you're diagnosed, you don't get the sort of prompts and support that you get through QOF. Are we treating them accordingly to target, to guidance? But equally recognise that actually what we're trying to do with most of these conditions is move the bell curve downwards. It's not just you're okay if you're below threshold and you're not okay if you're above threshold. It's more about moving the bell curve downwards. And for some conditions, are we over-treating patients? And that can be quite subjective, but certainly we know in elderly patients, if we get their blood pressure too low, that can increase their risk of falls. And whilst those blood pressures might be completely appropriate for an individual, you might still want to think about reviewing them. We then looked at various key indicators and the resources that we have. So along with the report that we publish, There are data tools that you can access online that will give you information breakdown down to practice, PCN, CCG level, to look at your relative performance against other people. The purpose of that is not to criticise, but it is to sort of highlight where, if you've only got 5 minutes, what can you get the most benefit for patients from those 5 minutes? So it's there to sort of help. It's not there to tell people off or to criticise. And again, as we alluded to, so we've got the 6 high-risk areas: hypertension, raised lipids, CKD, non-diabetic hyperglycemia, and diabetes, and how we work through the different cohorts within the audit. This is what we got on the participation. So 94% of practices signed up. We got 79% of data. Some of that was technical issues. So there's a huge number of patients involved in this, and a huge number of records. And in the second extract, we've got much better pickup rates than this from practices. And then this is the sort of information that we're trying to get from the audits that we're showing. So this one's looking at sort of atrial fibrillation here. And so it's showing on the little graph there, the bar charts, the prevalence against age for age and sex. But one of the things that we know is, when we look at age and sex, is that many of these conditions become more prevalent as people get older. But we also know that deprivation is related to age. So we know that people in the most deprived groups tend to be younger, mainly because they're unfortunately dying sooner. And what we've done in this is we've done some modelling against the age stratification for the different deprivation groups to try and work out, are we recording fewer AF patients in the most deprived group of people? We know they have poorer outcomes, but is that because we're detecting less AF in those groups? And from the analysis that we have at the moment, this wouldn't appear to be the case. Now, there is a caveat in that this is mathematically modelled. We didn't have the full practice information for the age breakdown, the size breakdown, and in subsequent audits we're looking to correct that. So whilst this is an interesting observation, we needed to do further work to be clear that that's a real development we can get from it. And again, when we're looking here, and again, mostly what I'm talking about on the slides is the elements of this that relate to deprivation and ethnicity, because I think that's the important part from the theme of the conversation today. So again, we're looking here at the difference in ethnicity groupings between those who are diagnosed. So again, we're most likely to be prescribed an anticoagulant in the white grouping, and least likely in the black ethnically deprived grouping. Now, having said that, we know that currently about 20% of the population that we had information for didn't have ethnicity recorded in their primary care database. NHS England are very keen that this is improved going forward, as are we. And really, until that's improved, that gap of 20% is probably too big to build strong conclusions from this sort of information. But it's interesting. We've no reason to suspect that the recording of ethnicity is any different than the ethnic breakdown of the population, but we don't know. This is an audit. It's not a piece of research. We didn't set out to answer a specific question. And again, when we're looking at hypertension, again, on the bottom right there in the narrative, the age-adjusted hypertension prevalence, it was slightly higher in the most deprived quintiles. So it doesn't look as though poorer outcomes for hypertensive patients are due to them not being diagnosed in the most deprived groupings. The next question, of course, is, well, have we diagnosed them? Are we managing them properly? And again, we didn't seem to see huge differences in the deprivation group between the management of it from there. I'm going through this fairly quickly in the interest of time, and I'm sure that there will be questions afterwards. So hypertension was slightly better managed in the ethnic Asian grouping, which is, again, interesting. I mean, with that caveat that we didn't know the ethnicity of about 20% of the population that we were looking at. But a lot of the reports around poor outcomes in Southeast Asian groupings for health determinants, diabetes and CVD risk, they definitely have poorer outcomes, but what do we need to do to address that? Where do we need to focus to reduce those areas, and that's the key thing. And I think that's where we're starting to get some information from CVD Prevent that might help inform some of those conversations and further research going forward. So again, this is more on the hypertension. Again, little variation between the deprivation quintiles in this area. Asian and whites are more actively monitored than the other ethnic groupings. And cholesterol. So cholesterol is an area that we all know is important, but it's an area that's not really been within QOF, and so it hasn't been looked at in great detail for a number of years. So one of the things that we looked at within this was patients with familial hypercholesterolemia or recorded as having familial hypercholesterolemia. As we all know, it's a genetic condition, so it's present from birth. And one of the key things you can see here is that the prevalence of this increases by age up to the 60 to 79-year-olds. Now, the prevalence of this is exactly the same in a 1 to 3-year-old as it is in a 60 to 79-year-old. And what this clearly shows is that we're failing to diagnose people, and we're failing to diagnose people at an age where we can really do something that makes a difference. These people have high cholesterol from birth, and even NICE recommends considering lipid therapy from the ages of 10. Before that, it's lifestyle and dietary modification. So we're missing for some of these patients 20, 30, 40 years of preventative treatment that's proven to be effective, and we're just missing it. We could do much, much better. But hopefully this and further work around lipid work, there's work on child parent screening for familial hypercholesterolemia. So there's lots of work going on, and genetic testing is within the long-term plan to really sort of highlight this area and focus on this going forward. Again, this was looking at managed to guidance from here, and again, people in the black ethnic groups are least likely to have a recorded prescription. People in the Asian ethnic group most likely to. Now, these are not big differences, 7%, and given that we've got a gap of 20% of the thing, we're not sort of trying to sort of put too much emphasis on this, but they're interesting to sort of say, as we get greater clarity on this information, greater confidence in this information, I think that's likely to lead to sort of further research, epidemiology, to say, where's the difference? What's important here? What's really happening? And again, cholesterol, and this is around the cholesterol in patients with CKD. We know this is a recommendation. We know this is an area where it's not been looked at previously, and we can see clearly there's variation across the years and variation between the different groups here. And this is the last one that I'm talking about really. There's a few other slides to follow this, but again, this was CKD. So again, after the age adjustment, the prevalence was slightly higher in the more deprived groups, which again sort of is counterintuitive to some of the things that people were perhaps thinking prior to the publication of this report. I think it's really important we address these inequalities and outcomes, but it's really important we address the inequalities and outcomes by understanding what it is that's triggering those inequalities. Is it a lack of care? Is it a lack of identification? Is it a lack of what we're doing in primary care? Or are there other factors to play? And those of you who follow Michael Marmot will see many of his very good messages around this area of work and what he thinks should be done to address some of these areas, some of which is within our gift as clinicians, some of which is without our gift as clinicians. But I always sort of feel until we've done everything we can possibly do, it's very difficult for us to be trying to hold others to account. So the first thing is get our own house in order as much as we can. We looked a little bit at comorbidities, so the overlap between some of the conditions there. I won't dwell on that. This is just mapping it out in a different way. So again, as you get older, you've got more of the comorbidities. I'm sure many of you will have seen similar slides to this in the past. And these are our sort of key takeouts, if you like, from the first report. We were trying to keep it headline, where This report is designed, as I said, to help people think about where within their practice or PCN or CCG they can get the most gain for patients most quickly. So if you've got 5 minutes, what do you spend that 5 minutes on doing? So within hypertension, yes, there's a link between hypertension and obesity. There's also a link between, females not being checked as much as male, and males of working age not having their blood pressure checked as much as women of a similar age. And we assume, we have no idea really, but this is because they're busy at work, allegedly. Women work as well, of course. But, so we don't know. But, there are things there where, these are younger people, and the importance of these conditions is the sooner we diagnose them and manage them, often with lifestyle at that early stage, the greater the benefit we'll get from those interventions. And this is just, again, for information. So this is where you can get the reports. You can get the data improvement tool, which is the part that gives you the breakdown by practice and PCN and CCG. Because we have to, if you break the numbers down too small, there's the risk that you start identifying an individual. So you have to then put some limits on how low you can go with some of these data fields. So we've got as low as we're able to do so sensibly and safely to prevent the identification of information. There's a list of the people we work with, so the NHS benchmarking, OHID, NHS Digital, NHS England. And equally, as I said at the very beginning, the tools that sort of UCL partners through Matt Kearney, and equally Gareth Forbes up in the Northeast do, which are free tools that you can download into your clinical systems to help you find the individuals. But rather than download everything and try and do everything, which is just, it's too much. It's sort of find the highest risk people first, find the people at really high blood pressure first, or the people who have no, and work backwards from that. So don't just look at everybody, but stratify what you're doing so that you can get the most gain most quickly. And I was going to stop there, but I'm sure when we get to the questions section, people will have some questions I'll be happy to try and answer.
Thank you so much, Peter. That was a great overview. I love that infographic, by the way. I can see that as being a great resource to help prioritise work in primary care. So fascinating stuff. Please do post any comments or queries in the chat panel for us to address at the end. I'd now like to swiftly move on to a personal perspective of primary care network cardiovascular hubs. And so over to Vishal Mashru to give that personal perspective. Vishal's head of medicines and research across 2 PCNs in Leicester. And these are PCNs right at the forefront of embracing the prevention strategy. So if we could just put Vishal's video up, that would be fantastic.
Good afternoon, everyone, and welcome to this presentation. My name is Vishal Mashru. I'm the head of PCN Medicines and Research at Cross Counties PCN and North Blaby PCN in Leicestershire. This presentation is going to take us through around primary care networks and the cardiovascular hubs that we've set up, and the latest results within those hubs. Now, all of this is around the identifying health inequalities, particularly around CVD prevent in primary care and as part of a long-term plan. This is a non-promotional event presentation, but it has been funded and organised by Daiichi Sankyo, and I've received honorarium to present today. These are my disclosures. So what I'm going to do, I'm going to set the background for this presentation, and then I'll take you on to the results and actually the benefits to what this will do for patients. So in terms of project background and why we consider this area as a focus, if we go back to 2015, cardiovascular disease accounted for a quarter of all deaths in England and affected quite a significant population, approximately 7 million patients in the UK.
Can we make sure everyone's mics are muted? We seem to have a bit of feedback.
It was around £9 billion. So, we can see that it has a significant impact on our patients, has a significant impact on our NHS health budgets as well. We then moved forward a couple of years into 2019 and 20, where the new GP contract and framework was developed alongside the long-term plan. And there was a real focus on patient care and delivering this patient care closer to where they live and closer to home. The investment that came as part of this contract in additional roles at primary care network level, which includes pharmacists who have had a real impact in being able to deliver some of that management around long-term conditions, but need the appropriate upskilling and education to go alongside that. And that's something that is being developed nationally, but also more locally within my PCNs as well. As I talked about, the NHS long-term plan was a key fundamental building block to how we developed a greater NHS and greater care to our patients. But one of the key aims around cardiovascular disease was to prevent 150,000 heart attacks, strokes, and dementia cases over the next 10 years, and also to increase out-of-hospital care. So earlier I talked about care closer to home. This is exactly what the long-term plan was set out to deliver. The long-term plan also emphasised that cardiovascular disease was one of the single biggest group of diseases where potential lives could be saved. Particularly focusing on strokes in England, because 2/3 of stroke survivors were leaving with hospital with a disability. If we just think about atrial fibrillation as part of that cardiovascular disease portfolio, then we think about in 2019 and 2020, the prevalence was just hovering around 2.05%. But that was an increase on 18-19, where it was just under 2%. And there were over 1.2 million patients with AF recorded in 2019 and 20. So let's focus on a more local flavour and the local background, particularly for Leicestershire and Rutland STP or ICS, how it is now recognised. So the STP ICS consists of 3 CCGs: Leicester City, East Leicestershire and Rutland CCG, and West Leicestershire CCG, and together they form the Leicestershire and partnership of CCGs and ICS into this coming year. Across the area, the AF prevalence in 2020-2021 was just below 2% at 1.94%, and you can see the respective CCG prevalences below in brackets. But also in 2021, from this data, we found that there was just under 7,000 people who had previously been diagnosed with a stroke in East Leicestershire and Rutland CCG alone. And again, when we then think about heart failure as another portfolio part of this cardiovascular disease bucket, we then look at the portfolio where the prevalence of heart failure was 1.1%, but an admission rate of just under 166 per 100,000 people in Leicester, Leicestershire and Rutland. In 2021, there was 19,000 people aged 17 or older who were diagnosed with diabetes, and this included the GP registers in East Leicestershire and Rutland CCG. Now, when you look at what percentage of the population that covers, that's about 7% of the total population within the CCG. However, the actual prevalence and diagnosed and undiagnosed is actually estimated to be much higher at 8.7%. So now I'm going to just take it even more granular. So we're going to look at just the 2 PCNs where we're doing this bit of work around cardiovascular disease and cardiovascular hubs. So across counties and North Blaby PCN combined a population of just over 106,000 patients. And these were the 2 practices that were 2 PCNs, that were participating in this joint working project covering 8 practices. And the mean prevalence is taken from the 1920 data in each of these PCNs for cross counties, 2.53% and 2.09% for North Blaby for atrial fibrillation. This was actually an increase in the atrial fibrillation prevalence across the PCNs from the data in 2018-19. And you can see also the number of patients actually on the registers in 2019-20 were 1,033 patients across counties, and North Blaby just over 1,300 patients. So we set up this fantastic cardiovascular hub joint working project. But actually, what were the project aims for this piece of work, and how are we going to get there? So I'll take you through the project aims to start with, some of the results, and where we are at this present moment in time. So the key project aim was to assess patients with cardiovascular disease and to ensure their management stays within primary care, linking back to the long-term plan, linking back to the GP contract to ensure that they're kept in that care closer to home profile. The other bit that I talked about very early in the presentation was upskilling the workforce, and particularly clinical pharmacists. So it was very much around upskilling and educating the clinical pharmacist workforce, which was again in line with the NHS long-term plan, the GP contract, and the primary care network specifications and direct enhanced specifications. And by assessing patients, by working alongside consultant cardiologists, consultant pharmacists, this would give them the confidence to be able to deliver the great care that we demand of our NHS. We then looked at what specific cohorts we were going to be reviewing as part of this hub working. And the 3 cohorts that came out of this were those that were needed management of prior patients, so our historic patients, our current patients with cardiovascular disease, particularly those with stroke. Looking at our post-MI and post-CVA care with patients in this cohort as well, and other cardiovascular conditions with complexity, so heart failure, valvular disease, even hypertension. And these were the kind of cohorts of patients we were looking to support, to look at their holistic care to see how we could better manage their conditions and prevent their risk at some stage in their lives as well. Operational model for this setup. We had a consultant cardiologist doing 2 sessions per week. We have a clinical pharmacist as part of the PCN doing 3 sessions per week, and then a consultant pharmacist looking at doing 1 session per week. And again, the levels of complexity of the patients will vary between those individuals, and it was a supportive model to work collaboratively between one another to ensure the patient got the greatest care possible. So let's look at some data, and the next few slides will take you through some of the data around what we've captured from sort of the 1st of April 2020 up until the end of March 2021. And this will just give you a feel for how many patients were identified, but also what has been done with these patients and what some of the findings were. And remembering that this is still an ongoing piece of work, so this is where we are now, but not necessarily where we will be in a few months' time as we start to progress the project even further. So as I said, this was the data taken across the practices in that period between the 1st of April and the 31st of March, and the data is reflective of that population of 106,000 patients across the 2 PCNs. And this data is actually based on GP clinical systems and coding. One of the other factors that is included is this is the number of patients that is based on QOF registers. So again, looking back to that 2019-2020 data. And it's really important to recognise that not all patients prescribed warfarin or a direct oral anticoagulant or DOAC receive these treatments for AF. So looking at the patients that were assessed in the cardiovascular hub between this period, we identified there was 2,379 patients within the AF cohort, and actually 697 of these patients were prescribed warfarin, and just over 1,800 patients prescribed a DOAC. Patients who experienced a stroke in this period were 62, and the number of patients that experienced a myocardial infarction in this same period was 44. And this really sets the scene for looking at how many patients within a population we have with the different types of medications, but also experience looking back to our aims, the groups of patients who experience some sort of cardiovascular event in that period. And then if we think about the breakdown of these patients, so again, for the same period of time, so April 2020 to the end of March 2021, looking at the types of patients and what kind of medications they were taking or groups of medications. So out of those patients that we identified, the 2,379 AF patients, 283 of these patients were taking no therapy or just an antiplatelet therapy alone. 54 patients, and warfarin is actually broken down into 2 cohorts. So you have patients with a time to therapeutic range of less than 65. And then the second grouping is the warfarin TTR of equal to or greater than 65. And this is really important because it gives you an appreciation of those patients that are well managed with warfarin or have a really good therapeutic index of warfarin. So warfarin patients in the less than 65 group, we had 54 patients, and in the greater or equal to or greater than 65% TTR, we had 387 patients. We then had 1,643 patients on a DOAC, and 12 patients on other therapies, for example, your heparins. If we now look at some of the data that was taken from April 2021, so we've looked at data from 2020 to 21, now taking data from the 1st of April 21 to 19th of January 22, so as close as we can get to today's meeting. We looked at AF registers again, that has remained the same, and partly that is down to the COVID-19 pandemic and protection of the quality and outcomes framework model for the last 18 months to 2 years. We see that the number of patients prescribed warfarin has actually decreased by 11%, and actually DOAC prescribing has increased by 27%. So again, looking at this data, we've got patients with AF again, the 2,379 patients, because the registers have remained the same. However, what we have seen is our patients with warfarin has dropped, so it's now at 621. We have that increase, as I described earlier, that has seen DOAC prescribing increase by 27%. And then we look at the numbers of patients who have experienced a stroke or MI in that period at 72 and 24 respectively. So this is really interesting data to see that actually we're seeing a shift in our prescribing to more novel medications, for instance the DOACs, and less prescribing of warfarin as the pandemic has almost dictated because of unavailability to do particular phlebotomy and blood tests and monitoring for these groups of patients. So we've seen that transition quite clearly in some of our practices. And then what I also want to share with you, during this period of time, we also did a review of a clinical review of these patients to look at what factors that may have come into consideration, but also what was found when patients were reviewed in this cardiovascular hub. So we look at patients that were receiving potentially incorrect dose of DOAC. And, out of our group of patients of about 509 patients that were reviewed, 38 patients actually were receiving the incorrect dose of DOAC. Patients prescribed warfarin was 106. The actual number of patients prescribed DOAC was 201. And then we start to look at some of the other parameters. So patients with a cholesterol greater than 6 millimoles per litre, 77. And our patients recently discharged for stroke and MI, 87, 66 and 21 across the two different groups. And actually, again, this is really important data because it starts to then show the value of having a cardiovascular hub or working in that hub type model, because we're now specifically reviewing patients looking at particular parameters, but actually finding that there's some patients that potentially would benefit from a review at some stage and also input from a cardiologist. And this has been really valuable to the work we've done across the primary care networks. Hopefully you found those results interesting, and I just want to finish on talking about the potential benefits for patients, particularly potential benefits for the primary care network as well, because I think it's really important to understand that the benefits that patients can have as part of this type of working. And as we are at this point in time, I particularly would like to share that it actually helps to prevent and reduce the risk of further complications associated with cardiovascular disease. And I'm hoping, from the patient satisfaction questionnaires that we've completed to date and some of the information that we're getting back from patients, it's actually improving their patient experience, but also the quality of life, because we're getting to patients and reviewing their medications and reviewing their cardiovascular care with a very specific focus. It provides them really important and valuable data, particularly around the sort of risks and benefits of assessment prior to referral to hospital, and where we can, keeping that care closer to the patient's home and in-house within practice. With the upskilling and the work of collaboratively working, it's ensuring that high quality disease review for patients and management of those diseases is at the highest level within our practices and PCN. It also allows patients the ability and enhances the ability of these patients to make informed decisions, but also making them a little bit accountable for their care and involving them as part of that shared decision-making process. We also like to ensure that patients get access to the pharmacological and non-pharmacological interventions, and they get this in a timely manner to prevent any further risks. And I'm hoping that as we go on throughout this project, this will be really well demonstrated in the patient satisfaction questionnaires that we receive back. In terms of the potential benefits for the primary care network using these cardiovascular hubs, particularly it's around maintaining that clinical excellence. And I talked about it as a benefit for patients, but actually it's a benefit for primary care networks as well. And we deliver that high quality clinical excellence for our patients. We're able to give more timely access to care. So we have a dedicated team working on this on a weekly basis. So looking at patients that would benefit from this care. We give access to existing NHS services. We can also refer those patients internally to get reviewed where we think they need reviewed by one of our consultants that are part of the programme. It also enables all of the leaders within the primary care network, not just those involved in the mini hub, but also all leaders to develop a strong set of skills and working together and clinical excellence to be able to deliver those high expectations that patients have expected of us and to deliver the goals of the project itself. It also has allowed us to create an infrastructure. So we know that we now have individuals working within our PCNs that are specialists, but also who can help and where do we go to for that help? Particularly financial control is very pertinent at this point in time, given the NHS and given the challenges around some of the financial control. But this has actually allowed us to not have to refer patients in, but also keep patients in-house and manage them and achieve some of that financial control through non-referrals where appropriate. And also activity levels. So, sharing the burden with our secondary care colleagues. We're also able to make that really substantial difference to patient care through changing the way that the culture of the NHS works and actually working in a different way to work towards that long-term plan goal and the aim of keeping that care closer to home, but also working together in partnership with other parts of the NHS. And finally, what I just want to finish on around the next steps for this cardiovascular hubs project and where we're likely to go with it. So particularly the COVID-19 pandemic has significantly affected the goal that we would have liked to have seen in terms of increasing patient numbers. But we're now at a point where we now have a greater clinician capacity. So we're looking to increase that number of patients seen per week. The plan is actually now to increase the number of sessions provided by a clinician to meet the original plan that we had of 6 sessions per week across the different teams. And we're looking to then look at that data quarterly to see if there's any changes in outcomes, also start to assess the questionnaires that are collected from patients or on the service as part of that cardiovascular hub, and if they're having the same benefits that we're seeing in their treatment pathways, and if they're seeing the benefits to that clinical care being enhanced for them. So hopefully that's taken you through a really nice synopsis of the project, and hopefully at some point we'll be able to share the further findings of what has happened in the hub as we go along. Thank you for your time today, and hope you have a great rest of the day.
Brilliant. Thank you so much, Vishal. Very eloquent presentation. I love this type of quality improvement activity, which really does reinforce the value of sort of PCN level work it really should help address those inequalities. So I thought some great ideas and strategies within your PCNs, perhaps, that many of us could look to implement in other areas. Would now like to get further insights and perspectives from the audience. I'm not sure if we can get our polls up, see if this is an opportune time. Is there any chance of having our polls put up? If not, let's just round off with our final session to end before the Q&A. One of the very few advantages to come out of COVID has been this increased appetite to embrace innovation, not just in terms of technology, but also innovation in terms of new ways of working. And I think to ensure a more sustainable and efficient use of resources, we have to find more ways of working with industry in particular to help improve patient outcomes in a mutually beneficial way. And so it's a great privilege to be able to get that crucial perspective from industry. We have Dr. Ravi Pawar, Medical Director of Daiichi Sankyo UK, and she will now discuss her company's support for CVD Prevent's vision.
Thank you for the introduction, Yasser. If my voice goes, guys, please forgive me. I had COVID 10 days ago. I've recovered, but just occasionally still coughing. To reiterate what you've just said, actually, it is so important that pharma looks at innovating to help achieve the goals of the long-term plan and help implement the findings of CVD Prevent. And to me, it's why I went into medicine. It's around prevention, it's around public health, and that's where our passions lie. And to be able to partner with the NHS, with NHS England, with industry to help achieve those goals is particularly exciting. And we heard what the pandemic has done, and something that really hit home to me, looking at it, is how many missed healthcare appointments there were, over 1 million in the pandemic. So normal health checks. So that's, just one example of how far behind the NHS is. So it is not just, I think it's absolutely crucial that industry plays its part in helping to help basically get more sustainability and work as a trusted partner. And Daiichi Sankyo, I joined Daiichi about 14 months ago, and it's really in our core that we work as a support for the NHS. We're committing to providing innovation that demonstrates value and supports this, delivering sustainable, high-quality healthcare, and the patient has to be at the centre of what we do. And you heard the example from Vishal, which is really getting care nearer the patient, and that's one example of a collaborative working project that we're doing. And we have quite a few others that are similar, but some with maybe slight differences in the technology. So as a company, we want to develop more meaningful transactions with all the people we work with, whether it's pharmacists, NHS England, and we've been working a lot over the last few years with particularly in cardiovascular care, to help prevent strokes through detecting and helping diagnose untreated atrial fibrillation. So we have a lot of projects going on across the country where we help diagnose atrial fibrillation in the population. We've seen from CVD Prevent the populations where there is more, especially the women in the 40 to 59-year-old age, where maybe it is more prevalent or less diagnosed, and we can target our projects at those age groups and parts of the country that need our help. And one of the ways we're doing that is through technologies like FibriCheck. So this is stuff that patients can actually do at home. It does not need to take up that valuable time in the GP's office or in the healthcare. So simple apps on your phone, which patients can then, over a short period of time, see if they have any suspicion of atrial fibrillation. They can then go into the health service and have that further diagnosed and managed. So that's one example where we're diagnosing patients with atrial fibrillation so we can get them treated, or the health service can get them treated, and then prevent the sequelae of that, such as strokes, which we've seen. Then also, then the next step of that is to protect people that have AF. There's an awful lot of people, as we've seen in the last hour, who may have atrial fibrillation, but either aren't on treatment or are not on appropriate treatment. And there again, we have tools that can sit and extract data from practices to help, and then do therapy reviews on those patients to get them optimally treated for them, on the right treatment for them, to help prevent the strokes. Then we can also play a part further down the line around education to help patients understand the reason for their treatment, so they stay on the treatments, because adherence, we know, is a big problem across medicine generally. And that also then helps keep them on the treatment that they need to prevent the sequelae of those conditions. So as well as atrial fibrillation, we're doing now similar partnerships in the cholesterol space. So finding untreated patients. We know that not all familial hypercholesteremic patients have been diagnosed. And we've seen from the CVD Prevent that patients with hypercholesterolemia, even when they've been diagnosed, are not always on optimal treatment, or they're not being treated to target. So here we are now looking at partnerships and joint working in selected areas where we can go in, extract data, and find those patients that need better treatment. Okay. So that is at the core of what we do. It's all about sustainable partnerships. And Daiichi's strategic objective, one of the main ones, is to be a partner of choice, which means that we aim to be trusted in everything that we do, keep the patient at the center of our joint workings. And these joint working projects are also shared on our website, so you can go and have a look at the ones that have been finished. That's basically how we work.
Thank you so much, Ravi. That was fantastic. I always find it refreshing to get that very balanced, very ethical viewpoint from industry. And as I said, I'll implore members of the audience again, we've got to look to find more ways of working together, in my view, for mutual benefit within this, what nowadays has to be a very ethical framework. So look, I'm very wary of time. We did have some technical issues. So again, I'm going to use my executive powers as chair to say we're going to overrun, if you don't mind, just by a few minutes. But it'd be interesting to get some insights from further insights from the experts, factoring in the comments. Please do have any burning comments or queries, just put them in the chat. But Peter, were there any findings from that first annual CVD Prevent audit? Any particular findings that really surprised you, or did they really confirm what you were suspecting?
So I don't think we necessarily went into it with sort of preconceived ideas. I mean, the whole point of an audit is to discover what's actually happening. And there's this sort of conversation, the espoused theory and the theory in action. So what we think is happening and what's actually happening. And as I mentioned, in some of the detail we got, because we get the information by age, sex, ethnicity and deprivation, and in future audits we're breaking down that into sort of serious mental illness and some of the other more disadvantaged groups, to try and understand exactly what's going on with those groups. And I think one of the things that would appear to be coming from the audit is that, whilst health and healthcare professionals do have a big role to play in identifying and managing these conditions, that isn't the single factor that's causing sort of the premature mortality in some of the more deprived groups or some of the ethnic groupings. It's a much more multifactorial causality, it would appear to be. I don't proclaim to be an expert in this area. I don't think the audit comes to conclusions around that. But I think with anything, it sort of takes the conversation further forward. And hopefully as we get the future audits out, we'll get more information from there.
Well, with such rich data, Peter, I mean, any good audit is just going to help you at least ask the right questions. And Peter, can you just confirm? I mean, there were 6% of GP practices, or 6% that weren't covered. Why is that, and what are we going to do to try and get?
No. So that wasn't a reflection on the GP practices. That was some of the. I think most of those were in using one of the GPIT systems that, for a particular technical reason, couldn't supply data to that audit to that point in time. So I don't think it reflected a reluctance on the part of clinicians to be involved in this audit. Okay. And the uptake in the next audit is much higher than the uptake in the first audit. So, we don't see. I don't see a pushback from clinicians in terms of wanting to participate and then therefore get the information out. And as I said, the important thing is the tools to help people find the individuals as well, so that you can help your patient. This isn't just about reporting on something. This is about helping people do something that will make a difference.
Yeah, I think, yeah, absolutely. I think with the right frame of mind, this is a very useful tool to help drive improvements in practice. Vishal, for me, the overwhelming issue with anticoagulation has to be, apart from detect, it has to be the perfect aspect. There was a question about how exactly did you assess whether patients were prescribed incorrect doses of DOACs, which for me is the overwhelming issue of this fantastic class of therapy. There is a lot of inappropriate dosing. How did you go about identifying that cohort?
Thanks, Yasser. I mean, initially we risk stratified these patients. So we looked at all of the patients that fell into the criteria of the joint working. We then, risk stratified these patients for those that have either had an MI or stroke very recently, because we wanted to get to them and optimize their care and make sure that they were, compliant with their medication, because that's always a key problem. We then had a group of patients that obviously fell outside of that hadn't had reviews or needed medication reviews and hadn't been followed up, partly because of the pandemic, for more than sort of 12 months. And out of these patients, we then started to identify there was potentially patients, whether their renal function had improved or their weight had changed drastically, or that their age had gone up in the last 2 years. And these are groups of patients that obviously need altering doses based on sort of the guidance for their DOAC. And whilst they were at that time on the incorrect dose, they potentially were not seeing any harm from their treatment, but there was obviously long-term complications if they remained at those doses. So that's initially how we did it. I'm sure Peter's described the UCL sort of frameworks, and again, there's lots of different tools out there to risk stratify your patients with, and we just used something very simplistic that would fit for our model.
In fact, I mean, I think that's great, but I have a very simple viewpoint. I think anyone on a low dose DOAC should be assumed to be incorrect until proven otherwise. There's a lot of that going on. And because valve disease is one of my great interests in medicine, can I ask Peter, is there any, I mean, it's the most preventable cause of heart failure, valve disease. Is there any scope in the future of including other sort of risk parameters within the CVD Prevent program, or are you just fixed to those 6 metrics at the moment?
So, well, those are the metrics that we're looking at the moment. As we do each of the audits, we're trying to expand the depth of information, but sitting again within those sort of 4 themes of, are we picking people up? Once we've done that, have we diagnosed them? Are we managing them properly? There is a national sort of advisory group that supports initiatives in terms of areas that might want to come into this going forward. I don't think there are any current hard plans for including valve disease within it, although if we can sort of get useful information out, then essentially this is to, how do we benefit patients? How do we, this is about how do we prevent cardiovascular disease? And if the audit just reports on things without being shown to make a difference to things, in my view, we've not achieved all we could do. So, the more difference we can make, the better.
Sadly, the time has flown by. I'm going to have to draw this meeting to a close. So I'd like to thank you, the audience, firstly, for your kind attention and great interaction. Apologies we couldn't get through all the questions, but I think that interaction really does bring these sort of meetings to life. We should also be very grateful to our sponsors, Daiichi Sankyo, for organising this meeting in a very non-promotional fashion, I have to say. And I thought it was a really good discussion where our expert faculty have given us their personal perspectives on CVD Prevent, as well as crucial strategies and practical insights in how we can make best use of the data, translate the outputs and learnings into meaningful clinical practice. So I'd like to thank my faculty for being an excellent bunch and a pleasure to chair. Please do make sure that you complete feedback from this session. We must, my final statement has to be almost a rallying call to action. We must really avail all opportunities to make the most of this initiative and make the most of this huge focus, unprecedented focus on cardiovascular prevention within the NHS. Our patients do lose so many good quality of life years to preventable cardiovascular disease. We really have to do everything in our power to claw back as many of those years as we can. And we do have that wonderful opportunity highlighted by our experts of adding both quantity and quality of life for our patients. So thank you very much for your kind attention, and have a good afternoon.